respected chairpersons and audience. I am presenting my paper, Early Renal Dysfunction in Non-Azotemic Cirrhotic Children by Renal Resistive Index and to assess the effect of paracentesis and albumin therapy, a prospective observational study. As we know, renal dysfunction is a common complication of cirrhosis. Serum creatinine is a biomarker of renal dysfunction. There are many files used with serum creatinine measurement, as it is falsely low even in presence of overt renal failure due to various reasons. Therefore, detection of early renal dysfunction before azotemia sets in is a challenging problem. Renal Doppler has been shown to detect renal vasoconstriction in several adult studies by renal resistive index. In this algorithm, we can see here, at this step, there is an activation of renin-angiotensin-aldosterone system that results in renal vasoconstriction that can be picked up by renal Doppler and plasma aldosterone level. This is the basically precursor of the acute kidney injury that can be picked up early. Aims of our study were to evaluate the renal resistive index and renal dysfunction in non-azotemic cirrhotic children, to assess the role of paracentesis and albumin therapy on resistive index in cirrhosis with severe ascites, and to observe the outcome of affected cohort till 90 days. This was a prospective study for 18 months at Pediatric Gastroenterology Center, SGPGI, Lucknow. Cirrhotic children between 6 to 18 years were included, having no ascites and severe ascites, with normal creatinine and GFR at admission. Exclusion criteria were given here. In study design, we grouped into cirrhotics grouped into two, severe ascites and no ascites. We did blood biochemistry and renal Doppler at baseline and day 90 in no ascites group. In severe ascites, we did at baseline 48 hours, day 7, day 30, and day 90. And similarly, we have done aldosterone at baseline, day 30, and day 90. Baseline measurements were taken prior to paracentesis and albumin therapy. Resistive index of each patient was average of 6 measurements done by single operator at upper, middle, and lower pole of each kidney with the help of this formula, and RI more than 0.7 was considered as renal dysfunction in our study. Acute kidney injury was defined as per Kedko criteria. Appropriate statistics were used. Ethical approval was taken in each patient. In patient enrollment, a total of 136 patients were screened. Patient with no ascites constituted 48, and patient in severe ascites we grouped into two. Patient receiving albumin group constituted 26, and patient who did not receive albumin 25. Now coming on to the results. Baseline data in patient with no ascites and severe ascites were comparable in terms of age, etiology, and serum creatinine. However, patient with severe ascites had low albumin, high INR, and PELD score. Similarly, patient with severe ascites had high baseline RI, high baseline renal dysfunction in severe ascites, and 2/3 of the patient with aldosterone had significantly high elevated aldosterone. Now we have analyzed patient with severe ascites separately in terms of renal dysfunction. Renal dysfunction in overall cirrhotics were 32, and in severe ascites 60%. We compared renal dysfunction group versus no renal dysfunction group. INR, PELD score, plasma aldosterone levels were significantly higher in group with renal dysfunction group. Here we wanted to see the relationship of RI with aldosterone. We could see that there is a significant correlation between the aldosterone and RI. There is significant correlation. In linear regression, PELD and aldosterone levels were significantly correlating with resistive index. Again, we wanted to see the dynamics of resistive index with aldosterone over 90 days follow-up. We could see improvement in 17 patients and worsening in 6 patients. Their change in the resistive index and with aldosterone were significantly correlating with each other. Effect of albumin on resistive index was very interesting. In albumin group, we could see there is a significant drop in the resistive index at 48 hours, day 7, day 30, and day 90. However, we could not see the same effect in non-albumin group. Outcome in terms of occurrence of acute kidney injury, recurrence of ascites, hospital readmission, mortality by day 90 was significantly higher in group those who had renal dysfunction at beginning. In this algorithm, we can see here renal dysfunction in terms of resistive index more than 0.7 was at admission 60% in out of 51 cases. Out of them, 53% developed acute kidney injury in group of renal dysfunction. However, patients without renal dysfunction, only 10% of them developed acute kidney injury. Their difference was significantly higher in patients with renal dysfunction group. For determination of outcome, PELD score was significant factor for development of acute kidney injury and mortality. In survival analysis, we could see patient without renal dysfunction survived better till 90 days follow-up. However, in patient with albumin group and non-albumin group, there was a similar survival till 90 days. At day 30, albumin group survived better. Strength of study, this was prospective study in pediatric cohort, and we could see correlation between renal resistive index and hormonal changes. However, we have not randomized albumin and non-albumin group. Now I am concluding my presentation. Resistive index is an easy, doable, non-invasive bedside method to detect renal dysfunction. Resistive index correlates well with plasma aldosterone. Albumin infusion has short-term benefit in cirrhosis with severe ascites. Resistive index is an important predictor to identifying high-risk group. Resistive index predicts acute kidney injury and also subsequent mortality in pediatric cirrhosis. Thank you so much.
So thank you for a very clear presentation and a nice and elegant study done by you. So the question really is, how are you going to use this study for future management of your patients?
Yes, sir. Thank you for your question. Actually, we know renal vasoconstriction is a precursor of development of overt acute kidney injury and subsequent mortality. So we can pick up renal dysfunction in terms of renal vasoconstriction so that we can diagnose renal dysfunction early before patient develop renal failure overtly. So that as we know, renal failure is a very important risk factor for even prognostic factor for post-transplant liver survival. So that early detection is very important for management.
So if you detect it early, you will send the child for transplant.
It's not...
Or modify your medical management.
We can identify the risk group among the patient with cirrhosis and severe ascites. If patient is having a resistive index more than 0.7, it means that those groups are very high risk for development of acute kidney injury. We can mobilize early.
Thank you. The other question I have is, did you correlate it with nutritional parameters and diet therapy in any way?
Yes, sir. Because of paucity of time and limited slides, we couldn't show. We have done BMI and Z score of weight and height. That's what similar in both group patient having renal dysfunction and without renal dysfunction. Patient with severe ascites having equal distribution of growth failure, sir.
Thank you.
One question, you had quite a wide spread of ages. Did age influence any of the outcomes?
Sir, we had taken 6 years to 18 years of group, and in no ascites age and versus severe ascites age distribution was similar, and patient who had renal dysfunction and non-renal dysfunction age was similar in both groups.
Thank you very much.